because it's quite important for men to have this sort of feeling that they're being useful. And if you can use that to help people to stop smoking, then I would see that as being quite acceptable. So we've talked about observation, we've talked about treat blood gas abnormality, we've talked about encourage expectoration, we've talked about prevent, treat infection, we've talked about general measure, we've talked about psychological support. Let's go on now and look at drugs. First group of drugs we're going to talk about are antibiotics. And antibiotics should be used as soon as bacterial infection is recognised. And remember, green or yellow sputum means bacterial infection. Of course, the antibiotic is going to depend on what you've got available. Something like amoxicillin or cefalocor would be suitable. And for some patients who get infections absolutely all the time, antibiotics may even be used in prophylaxis. So, antibiotic therapy. Really, probably antibiotics are particularly important in acute disease. Although for otherwise healthy people it normally resolves anyway, so some degree of discernment required as to when to use and not use antibiotics. So antibiotics, let's mention bronchodilators. Next group of drugs we're thinking about. These can reduce respiratory workload by dilating the bronchioles, therefore making it easier for air to get in and out of the lungs. We check with peak flow measurements before and after. And depending on the bronchodilator, actually, some bronchodilators work quickly, so you'd check the peak flow fairly quickly after giving the bronchodilator. Others have a more delayed effect, so you might want to check it a bit later. But monitor the effectiveness of bronchodilators with peak flow, and we discussed that in some depth on the video on asthma. And of course, observation for effects and side effects of bronchodilators is important. For example, the sympathetic stimulating drugs like salbutamol can cause tachycardia. Really, it's the anticholinergics which are probably most appropriate for use in chronic obstructive airways diseases. They often give better and more prolonged effects. For example, ipratropium, often given by inhalers. So that's antibiotics, bronchodilators. Let's think now about the role of corticosteroids. So corticosteroids, in established disease, these should be tried as there may be unsuspected reversible inflammatory elements to the condition. So it's worth a go with corticosteroids in anyone with established disease because some patients get very significant benefit. For example, physicians will probably prescribe prednisolone 30 milligrams a day for a couple of weeks. And if these are beneficial, very often the patients are kept on corticosteroids by inhalation, possible maintenance with inhaled corticosteroids. So antibiotics, bronchodilators, corticosteroids. Let's think about diuretics. And of course, the role in diuretics is for edematous patients. Patients with systemic edema can benefit from diuretics. Antibiotics, bronchodilators, corticosteroids, diuretics, and finally respiratory stimulants. May arouse patients and stimulate coughing, but personally I've never used these, so I'm not going to comment on them. So we've talked about management, observation, treat blood gas abnormality, encourage expectoration, prevent, treat infection, general measures, psychological support, drugs including antibiotics, bronchodilators, corticosteroids, diuretic therapy and possible respiratory stimulants. Now we're going to go on and look at how these patients can be managed effectively in the home. Well, this is difficult depending on the circumstance, but in severe established disease, continuous oxygen at about 2 litres a minute can be given via a nasal cannula. So additional long-term oxygen support at home is a possibility. And the aim is to keep oxygen saturation levels at above 90%. Now, in a healthy person, oxygen saturation should be about 99 or 100%. But the aim is to keep oxygen saturation above 90%. Now, can you think why these patients might benefit from long-term oxygen therapy? Well, remember, the alveoli, the blood supply to the alveoli is reduced. That is, there's pulmonary artery vasoconstriction in response to low levels of oxygen in the alveoli. And it's this pulmonary artery vasoconstriction which gives rise to the cor pulmonale. So if we can keep the levels of oxygen in the alveoli high, then we can prevent the branches of the pulmonary artery vasoconstricting. That will prevent the pulmonary arterial hypertension, and that can prevent the right ventricular hypertrophy, so will prevent the right-sided heart failure. So giving patients low levels of oxygen to keep the O2 sat, the oxygen saturation, above 90% can benefit the prognosis. But of course this is very often difficult to do because it needs a constant supply of oxygen. So other things we can do at home, possible use of nebulizers for humidification and inhalation of drugs. And just to go back to the oxygen point, at 15 hours a day of extra oxygen, there's a detectable fall in pulmonary artery pressure. Now I know this is difficult, but if a patient can be given this additional oxygen at home, then this benefit can present. And at 19 hours a day, if a patient can be having 2 litres of oxygen, a flow of 2 litres of oxygen a minute, for 19 hours a day or more, there's a substantial improvement in the mortality. So this can be a substantial benefit. We're talking about low oxygen concentrations. Exercise training, next point. May reduce feelings of breathlessness and improve the overall well-being of the individual. So at home we can humidify the air, we can give them extra oxygen available, and we can get the patients as fit as possible, as well as paying attention to the other things we've talked about, such as diet, not smoking, early detection of infection. And a major nursing role, of course, is to educate the patient, to gain the cooperation of the patient, and therefore optimise their compliance. So nursing management, observation, treat blood gas abnormality, encourage expectoration, prevent, treat infection, general measures, psychological support, drug therapy, antibiotics, bronchodilators, corticosteroids, diuretics, possible respiratory stimulants, management at home, keep oxygen saturations above 90% with low levels of oxygen, nebulise the air, pay attention to nutrition, keep the patients as fit as possible, optimise patient compliance. And finally in this talk, let's think about the prognosis. If the patients are severely breathless, then 50% will die within 5 years. But even in the severe group, patients who already have severe disease, the disease is not reversible, but even in these patients, stopping smoking improves the prognosis. Right, well, having looked at bronchitis and emphysema, we're now going to look at oxygen therapy. And the first thing I'm going to think about is why might you want to give someone additional oxygen? Now, the air around about us has got 20% oxygen in it, and for most of us, for most of the time, this is enough. But sometimes, when the patient's unwell, for various reasons we're going to look at, they need a higher concentration of oxygen than is available in the atmosphere. So why might someone need oxygen? Well, the reason is that there's a lack of oxygen in the blood. That's referred to as hypoxemia. Hypoxemia, low oxygen in the blood. And this is important because it means that there's not enough oxygen in the tissues. That's called hypoxia. So if there's not enough oxygen to the brain, that will result in cerebral hypoxia. Not enough oxygen to the other parts of the body, then those organs will also be hypoxic. And of course, oxygen is necessary for every cell of the body to produce energy. Without it, it will die. So let's think about briefly, just to start off with, the causes of hypoxia. The first cause of hypoxia is hypoxia caused for extrinsic reasons. That means there's not enough oxygen in the atmosphere. So like if someone's locked in a room and suffocating, that would be extrinsic hypoxia because there's not enough oxygen in the air around about them. Or if they're in a gassy environment and they're being gassed, the cause of the hypoxia would be extrinsic. Or if someone was in a garage filled with exhaust fumes, for example, then again that will cause extrinsic hypoxia. There's not enough oxygen in the air. So that's one cause of hypoxia. Second cause is pulmonary hypoxia, and that's hypoxia because of lung disease. So if, in chronic bronchitis and emphysema, for example, then the hypoxia is pulmonary hypoxia because it's caused by inadequate lung function. The third possible cause of hypoxia is caused by shunting, arterial to venous shunting. And this occurs in various congenital abnormalities, such as when there's a hole in the heart. That's a communication between the atria normally, an atrial septal defect. Or there's another one called patent ductus arteriosus, where there's a communication between, I can't remember, the pulmonary artery and the aorta, I think. But what happens in these things is that deoxygenated blood gets mixed with oxygenated blood. So that means that there's less oxygenated blood in the arterial supply, and that results in tissue hypoxia. The fourth possible cause of hypoxia is anemia, transport hypoxia, when the blood can't carry enough oxygen to the tissues. So if someone's very anemic, there's a reduced oxygen carrying capacity in the blood, therefore the tissues become hypoxic. And the fifth cause is histotic hypoxia, an inability of the tissues to actually use the oxygen that they get. And this occurs in poisoning, for example, cyanide poisoning, but it can also occur in vitamin B deficiencies. So most of the time when we're talking about hypoxia, the reason is due to lung disease, pulmonary hypoxia, but by no means always. And if you want more details on hypoxia, there's actually a separate video on the subject. So let's just review briefly what we've said on these notes to clarify the position. So oxygen is administered when there's a deficiency of oxygen in the blood. That's hypoxemia. Because hypoxemia, low oxygen in the blood, will lead to low oxygen in the tissues where the oxygen is required. Causes of hypoxia: inadequate oxygenation of the lungs for extrinsic reasons, hypoxia secondary to pulmonary disease, and of course this can include lots and lots of lung diseases, venous to arterial shunting, when the blood is unable to transport the oxygen from the lungs to the tissues, so inadequate transport, often referred to as anemic hypoxia, and finally inadequate inability of the tissues to use the oxygen, referred to as histotic. Histotic means related to tissues, as in histology. So as a nurse caring for any patient, it's important to ensure there is adequate oxygenation of the tissues, especially thinking about the vital organs such as the brain, the heart, the kidneys and the liver, which require a constant oxygen supply in order to metabolize. So sometimes additional oxygen may be required. And as nurses, very often we start this up. We give someone extra oxygen when we think they need it. But we should get a medical approval for it when we can. So ideally it's prescribed, but very often we do start it ourselves. And very often we need to start it ourselves in in situations where the patient needs it fairly urgently. Now, different patients at different times with different conditions require different amounts of additional oxygen. And we measure this in terms of percentage. So it's important to know how much oxygen the patient requires in terms of percentage and how to measure it. And the measurement is usually worked out by a combination of the flow rate in litres per minute and the type of mask. Flow rate in litres per minute and the type of mask. So I'll just show you a bag here from a typical oxygen mask. Now, you might not be able to see this very clearly, but this is just a bag that the mask came in. And for this particular mask, an oxygen flow rate of 2 litres a minute will give an average oxygen concentration of 29%. An oxygen flow of 3 litres a minute will give an oxygen concentration of 34%. 4 litres a minute will give 38%. 5 litres a minute will give 42%. And 6 litres a minute will give 46%. But of course, that is specific for this particular mask. So it's important to read the manufacturer's guidelines with the particular mask, because the amount of litres per minute to give a particular percentage of oxygen will vary depending on the type of mask, on the particular mask, and the way it mixes oxygen with atmospheric air. So each one you have to assess separately to work out the concentration. Now let's think about when we might want to give high and when we might want to give low concentrations of oxygen. Just a few examples. Well, high concentrations of oxygen are used sometimes after anaesthesia, and certainly in emergency situations we use high concentrations of oxygen whenever there's interference with airway, breathing or circulation. Another example when it might be used is carbon monoxide poisoning, where we use high concentrations. Now, what about when we use lower concentrations? Well, 24% oxygen is given. That's only an additional 4% over atmospheric air in chronic chest conditions. So if someone's got a chronic chest condition, we give them low concentrations of oxygen. Now, you might wonder why it's worth giving such a small extra concentration of oxygen. Well, the answer lies in a reasonably complex area of physiology called the oxygen dissociation curve. And this is an S-shaped curve, and part of the curve is steep. And what that means is that for a little increase in oxygen concentration, you can get a lot more oxygen absorbed into the blood. So for someone with chronic obstructive airways disease, that 4% extra oxygen can make a big difference to the amount of oxygen carried in the blood. So it's well worth doing. So high concentrations and low concentrations depending on the patient's condition. And the percentage concentration, as we've said, is achieved by controlling the flow rate in litres per minute and by the mask. A particular mask with a particular flow rate will give a particular concentration. Now, oxygen should be humidified if it's given for long periods of time. And there's different ways we can do this. And I've got a simple device here that we can use for humidification. So I'm just going to take the top off this. This is a very simple sort of thing. Trouble is I've got a glass of water in my hand. Take the top off that. Right. And I can put some water in there. Actually, this is normally used for giving nebulized drugs, but it works. It will humidify as well. Then the oxygen supply is connected to there. Then the mask going to the patient is connected there, and you can see this bubbles. What if it didn't leak? Anyway, I think you get the idea that it can go through there, through the water to be humidified. Now, the reason that we want to humidify it is that when you humidify it, you add water to it. You get lots of little water dropules and water vapour in the oxygen. because the oxygen supplied in cylinders and pipe supplies in hospitals is quite dry. And if that's given for any period of time, the dry air will tend to dry out the patient's airway, which you want to avoid. Because if the airway dries out, it means the secretions produced by the chest will no longer be mobile, and the cilia won't be able to waft them up to be coughed up. So you'll get dry, encrusted sort of mucus, and that's going to become infected and cause all sorts of lung problems. So patients that are on oxygen for any length of time, the oxygen should be humidified. So oxygen should be humidified, given for longer time periods. And a written record of the times and the levels of oxygen administration should be kept, so we know how much oxygen the patient has had for how long. And some patients require long-term oxygen therapy for chronic conditions at home, if this is available, of course. Now, of course, when we're carrying out any nursing procedure, as well as our nursing skills, we need to be familiar with the equipment. So let's think about the sort of equipment we're going to be using in administration of oxygen. Well, first of all, the oxygen supply. Always got to make sure we use the correct cylinder or the correct wall supply. A bit difficult to get this wrong, but it could happen that a patient was actually given the wrong gas, because we have different gases you use in hospitals, and we must of course use the right one. So oxygen cylinders in the UK anyway, at least all the ones I've come across, are black with a white band around the top to indicate their oxygen. Air is carried in usually greyish cylinders which have a black and white banding on the top. And just to give another example, blue cylinders with a blue and white top are Entonox. But of course, if you're in a different area or different country, that may be different. So what you've got to find out is how it is coded in your area. You get different sorts of flow meters. Normally they'll have a tap on the bottom for turning on and off, something like that. And normally they have some sort of chamber with the flow rate in litres a minute normally. Something like this. Something like that. And there's a chamber up the middle. And what normally happens is there's a float in here in the chamber. Another colour so you can see it. So when the float is there, it's very obvious that you're giving 6 litres per minute. But these will of course vary depending on where you are, and then there'll be an output port there for the oxygen to connect up your tubing, and you connect your tubing to this part, to the patient there. And the supply normally comes in from the back actually. So you adjust the knob till you get the float at the level you want, and on all the flow meters I've seen, they've always been in litres per minute. So normally quite a straightforward matter, using the flow meters to set the flow of oxygen in terms of litres per minute. Now the tubing. Very often here we use this green variable length type tubing. It's got thicker bits and thinner bits. This is typical type oxygen tubing. We call it bubble tubing actually. And the reason it's got thicker bits and thinner bits is you can chop it at a thick bit if you've got to put it on something thick, and a thin bit if you want to put it on something thin, because of course you always want to ensure there's a good seal round about the tubing and the mask or the source, otherwise the oxygen will just be leaking. Different tubing available. This is a slightly wider one. And when you're giving humidified therapy, it does need to be wider. So green bubble tubing, fine for short-term therapy, but use wider tubing for longer-term therapy when humidification is required. Because if you use narrow tubing with humidification, the water tends to, condense out into the tubing rather than be carried on to the patient. So thinking about masks, here we see a fairly typical type of disposable mask within a piece of elastic goes around the patient's head and can fit on over the mouth and nose and they can breathe through that, but I can't talk through it, so I'll take it off. And these often have another tubing here connected up to them. And you'll notice here there's another part that determines the concentration of the oxygen. So obviously you need to use the right tubing with the appropriate mask to make sure the concentrations are accurate. And then the actual delivery tubing just fits onto the bottom of that. And this goes off to the oxygen supply. So different sorts of masks. So thinking about the masks, or sometimes you just use nasal cannula that just fit into the nostrils as another way to deliver the oxygen. So some venti masks allow air to mix with the oxygen to control the percentage accurately, as we've already discussed. Now, normally, if you're giving oxygen for a short term, it's not so important to control the concentration, but for longer term therapy, it becomes important. And it's particularly important in chronic obstructive airways disease that the concentration is known. And it shouldn't exceed 24% in chronic chest conditions. So different masks, I mean, I'm not going to talk about all the different masks. What you need to do is find out what is available locally to you, work out what concentrations it supplies, work out how to use humidification, and generally familiarise yourself with the equipment that you're going to be using on a day-to-day basis. But these are the principles. So nasal cannulas, for example, will allow more freedom of movement, but give lower concentrations. So I've got an example of a nasal cannula here. There's a single tube supply from the source. And these just comes into a double source there at this junction box. And these just fit round the patient's head. And the cannulas just go into the nose here. So as the patient breathes, oxygen is being delivered directly into the nose and leaves the mouth free, and the patients can walk around and things to an extent. So different ways of delivering it. Nasal cannulas there, for example. And tents and incubators, oxygen tents may be used for younger children who wouldn't tolerate using a mask or a cannula. So in this circumstance, normally you'd put the child maybe if they're on a bed, say, you'd put the tent all over the bed like this and fill the whole atmosphere with the enhanced amount of oxygen. Young children and infants. This is the way that neonates are nursed, for example, in incubators. Right, humidifiers. We've mentioned that very often the oxygen needs to be humidified. And very often, as we saw before, well, the one we saw before actually had water in. And the oxygen supply would actually bubble through the water and then be taken off there and go to the patient. That would be the top of the container. You'd have to have a top on, obviously. So the oxygen would be coming in here, picking up the water from here as it passes through the water, and then leaving here to go to the patient in a humidified form. Although very often they're not like this, they're similar, but the oxygen, you have water in there again, and the oxygen actually just blows onto the surface of the water there like that, and then it's taken off again on this side, and again that humidifies the oxygen quite effectively. So just the fact that the oxygen coming in is blowing on the surface of the water means it picks up enough oxygen. There'll be water in there to humidify the supply going to the patient. So the water may be warmed if that is necessary, and I didn't in my demonstration, but I wasn't giving it to a patient, but you should use sterile water for irrigation to prevent the possibility of any contaminants in the water being inhaled into the patient's lungs. So we've looked at equipment, we've looked at the supply, the flow meter, the tubing, the mask, and the humidification. Let's now go on and think about specific nursing aspects of oxygen therapy. So thinking about nursing aspects, well, obviously appropriate explanation to the patient is vital. If they know, because the patient needs to know what's going on so we can gain their full cooperation and the patient is relaxed about the procedure. So as always, we need to take time to communicate in ways the patient can understand, give them appropriate explanation of the procedure, as with any procedure. And one of the extra things with oxygen therapy is very often the mouths do get a bit, I know they shouldn't, but they do get a bit dry and sometimes a bit sore. So pay attention to mouth care. And these days we're not tending to use lotions like glycothiamol and things. We just use toothbrush and toothpaste for mouth care. If the mouth's clean and moist, it should look after itself. And a major part really of nursing care is observation of the patient's condition. How are they responding to the oxygen therapy? For example, are they cyanosed? What's their respiratory rate? How deep is their inspirations? Is it gasping? Is it wheezing? Are the chest movements symmetrical? So all your nursing observations of the patient's respiratory condition are very important, as well as observing the respiratory rate. How distressed are they? How easily are they breathing? This can be aided with spirometry and peak flows. And the mental state of the patient is often a good indicator. Patients that are becoming hypoxic can become confused and will lose consciousness actually fairly quickly. So diminished consciousness may be a sign of acute hypoxia. And other things like level of dyspnea we've mentioned, orthopnea, are they short of breath when lying down? So quite a lot of nursing observations to monitor the effectiveness of the oxygen therapy that you are giving. Now, if you're fortunate, and we're about to demonstrate this, you'll have access to pulse oximetry. Now these devices are quite expensive, so you may not have one available, but if you do have, then they're remarkably useful. This one is a portable model, and it consists of this bit here, which we'll see in a minute. And what you do is you put this probe on the patient's finger. You put it through the fingernail, and I think we can see there's we see the red light in there we can see it. There's a red light here, there we are, flashes through the fingernail bed, and somehow in a clever way that registers how much oxygen is, see that again. There we are. That registers how much oxygen is going through the patient's finger. There, you can see it there. So, Catherine's our patient today. She's not really a patient, she's a student nurse, but we're going to put it on her finger and we'll see what's happening. So, make sure it's properly lined up, going through the fingernail like that, and then we'll see what result we get. Well, she's in a stressful situation at the moment, so pulse rate is about 90. So this is the pulse rate here. This is me, I've intimidated her, I think. But the important thing is here, the oxygen saturation is 98. So we've got 98% oxygen saturation, and we've frightened her a bit, so her pulse has gone up a bit. But it'll settle down now. You see there, it's settling down now. Down to about 94. But normally it's quite fit, so normally it'll be about 75 or something. But the important thing is we've got 98% oxygen saturation. 99% oxygen saturation. And that's just breathing ordinary atmospheric air, so that indicates that everything is in quite a healthy status in Catherine at the moment. There we see her pulse rate settling down now. You often do see this when you put patients on pieces of equipment that it's a bit unfamiliar. Let's just try. I mean, mine's probably high as well because I've been dashing around picking this thing up from the hospital. Let's see what I've got. Right, so at the moment my pulse is, what's it going to be? Mid-70s, 76 there. And oxygen saturation, again, 98%. So we can see the oxygen saturation, and from that oxygen saturation we can decide that at the moment, Kath, I'm pleased to say neither of us need oxygen therapy, so we can accept that. So very simple device, quite expensive unfortunately, but excellent for monitoring the amount of oxygen the patient requires, and indeed if someone comes in with a chest infection or something, you can check their oxygen saturations and you get instant information, and that didn't hurt, did it?
No, not at all.
Completely non-invasive therapy, so very useful device if one is available. Of course, if not, the other way that this is done is sometimes by using by looking at blood gases, looking at arterial blood gases. And of course, that's very invasive because you've got to go into an artery to get the blood sample. So pulse oximetry, excellent aid to nursing observation if available. So, monitoring the amount of oxygen the patient's receiving. Now, one thing to remember is that patients that are getting oxygen therapy very often will be unwell anyway, that's fairly obvious. And people with infections or other illnesses are more prone to opportunistic infection. So make sure the delivery system is not infected. Now, this would mean that the system is either a new system, if it's a disposable type setup you're using, or if not, you'd have to make sure the equipment was properly cleaned and, of course, ideally sterilised. What you must be certain of is that you're not passing an infection from one patient to the next. So if equipment's been used on someone with, say, pneumonia, then clearly it must be sterilised before it's used on someone who's got another condition, or even if they have even another patient with pneumonia. No cross-infection between patients. So sterilise the equipment or use new disposable equipment. And patients who are on humidified therapy for long periods of time might be at more risk of infection because bacteria can be carried into the lungs in the water particles. And water particles in the air may transport bacteria in humidified oxygen therapy. O2, of course, is oxygen. So any patient who is receiving oxygen therapy should be observed for infection. They should be nursed sitting up where possible. Encouraged to cough to expectorate any sputum that they're producing. Chest physio may be appropriate, and as we've said, new or sterilised equipment should be used on a new patient. Now we need to think about some physiology now, the physiology of respiratory control. The reason that you breathe is because your diaphragm goes down, your ribs go up and out. That increases the volume of the chest. As the volume is increased, the pressure is decreased. Therefore, air is sucked into the lungs to equalise the pressure. That is how you inhale. So respiration is controlled by diaphragm, intercostal muscles, and to some extent the accessory muscles of respiration as well. But what is it that controls those muscles? Well, it's the nervous system that controls those muscles. And ultimately, the impulse to breathe arises from the medulla oblongata in the brain stem, from the respiratory centre, in fact, in the brain stem. And in health, the respiratory centre is stimulated to send these impulses to the respiratory muscles when the amount of carbon dioxide in the blood increases. So the reason we breathe actually is not because we need oxygen, well of course we do, but the reason we breathe is to blow out, to exhale, to excrete carbon dioxide. It's the rise in CO2 that stimulates respiratory effort. And that's the case in someone who's healthy. But in someone who's got chronic lung disease, for example, chronic bronchitis and emphysema, then they have got high levels of carbon dioxide all the time because they have difficulty breathing out. So they've got chronic high levels of carbon dioxide in the blood. And this means that the part of the brain which responds to high levels of carbon dioxide is overwhelmed and does no longer respond to it. It's flooded, if you like, with carbon dioxide. So patients with chronic airways conditions, chronic lung diseases, don't breathe because the amount of carbon dioxide builds up. They breathe because the amount of oxygen in the blood runs low. Can you see the difference? In health, you breathe because the amount of carbon dioxide builds up. In chronic obstructive airways diseases, chronic lung diseases, the patient breathes because of oxygen lack. It's kind of a backup system, if you like, a reserve system that kicks in only after long periods of time with chronic airways disease. So they're breathing because of oxygen shortage. The CO2 level is always high. So if you give them a lot of extra oxygen, there's going to be a lot of extra oxygen in the blood. Therefore, they're no longer going to be stimulated to breathe by oxygen lack, because there is no oxygen lack because you've put a lot of oxygen in. So what's going to stimulate them to breathe? If there's lots of oxygen in the blood, well, nothing is, and they can slow down or even stop breathing. So for this reason, it's an absolutely golden rule that unless someone who really knows what they're talking about, preferably a physician or an anaesthetist, says give this patient more oxygen than 24%, we don't give them more than 24%. Unless, of course, it's some other a very acute emergency when we can observe them all the time. So the rule of thumb is oxygen at 24% in chronic conditions and no higher unless there's a very good reason or someone who knows what they're talking about says to give them more. So that's the rule, 24%. I'm just going to put a few notes down. I'll let you read through these on your own, I think.